Hi, Doc. How are you?
Hi, I'm good. How are you?
I'm okay. You can confirm you can share your slides.
Yes, please, let me do that.
Okay.
You can see them.
Yes, now I can.
Okay.
Okay, we'll wait for, I think you're good to go. We'll wait for Dr. Valerie who join.
Okay. Let me just check if they're moving.
Yes, they have moved.
They've moved.
Yes.
Okay, great. Sawa sawa. We'll just wait.
Yes, thank you.
Karibu, thank you.
Good evening, everyone, and welcome to today's session. My name is Dr. Valerie Erulu. I'm a medical officer working at the Cancer Treatment Center at Kenyatta National Hospital, and I'm going to be your moderator for this evening. So, today's topic is depression and anxiety in children with palliative care needs. And the speaker taking us through this topic is Dr. Weremba Masiga. So, Dr. Weremba is a dynamic medical doctor dedicated to providing holistic mental health care. Dr. Weremba is specializing in psychiatry and has a special interest in pain management and palliative care. She is committed to delivering quality palliative care and pain management from a mental health perspective and is an advocate for children's palliative care and proper end of life care. Her areas of focus span across women's mental health, sleep medicine, geriatric mental health, and spirituality in healthcare. So she is currently a resident at Madari National Teaching and Referral Hospital and a psychiatry registrar at Vital Africa. Dr. Oremba sees a myriad of patients with mental health illnesses and leverages her clinical acumen, research capabilities, and leadership skills to offer comprehensive therapeutic interventions. Um, she also holds a Bachelor of Medicine and Bachelor of Surgery degree from the University of Nairobi and a Master of Science in Pain Management from the University of South Wales, and is pursuing a Master of Science in Palliative Care from Makerere and Master of Medicine in Psychiatry from the University of Nairobi. So, as a lifelong learner, she's also currently working on a certificate in leadership and management from the University of Washington to gain knowledge and improve her leadership skills. And on top of that, Dr. Remba is a personal friend with whom I've had the opportunity to work closely with. So, Daktari, the floor is yours. You can take it away. Thank you.
Good evening, everyone.
Good evening, Doc.
Thank you, Dr. Valerie. I'm just wondering, is my camera on? I wanted to show my face before we proceed. Okay, that's okay. We can begin. So today's topic will be on depression and anxiety in children with palliative care needs. So we'll just touch briefly on what the psychiatrist's role is. We know that palliative care, children in palliative care have chronic illnesses, and some of them have illnesses that are really advanced. So with this comes a lot of psychiatric disorders. And it's important to involve a psychiatrist in the interdisciplinary team just to make sure they're well and holistically taken care of. So depression, anxiety, and delirium are very common among palliative care patients, and accurate diagnosis and appropriate treatment can be challenging. We'll see why shortly. So pediatric palliative care is a new and rapidly emerging medical specialty, and psychiatrists have a critical role to play. So when it comes to depression, we've already noted that symptoms of depression are common among patients with complex and chronic disease. And the diagnosis is challenging because some of the symptoms and signs they exhibit are similar to what some of the signs and symptoms of their main disease are. And in a lot of cases, patients and families feel that being depressed with a chronic illness is normal and not an indication to seek help. And we find in some cases that clinicians, especially those who are not well educated and don't subscribe to holistic care, may share this thought. You find patients saying, of course, I'm depressed, I'm dying. So like we've mentioned, some of the somatic symptoms of depression are similar to the physical symptoms of disease. These include change in appetite. You may have decreased energy, change in your sleep pattern, and an inability to concentrate to make decisions. So today's focus is on children under palliative care. So when it comes to depression, we'll discuss the symptoms in terms of groups, for example, emotional, physical symptoms, etc. So when it comes to emotional symptoms, you'll find that some patients exhibit sadness or low mood. The child may express feelings of deep sadness, and they may be tearful and cry frequently. You'll also find that some children express hopelessness. They tend to ask, what's the point of me being here? I'll never get better. Some children also exhibit loss of interest or pleasure, known as anhedonia. So they tend to start losing interest in the things they used to enjoy, such as their hobbies, playing with other children, or participating in family activities. They seem indifferent to things that used to make them happy. So there's feelings of guilt and worthlessness as well. The children might start believing that they are a burden to their family and that the illness is their fault. They might even struggle with self-worth and make negative self-assessments. So because these are children, they're not able to express themselves using words. So you'll find the young ones and also maybe the teenagers exhibiting irritability or anger. They're easily frustrated, they lash out, they have temper tantrums. Then you'll find some children start socially withdrawing. If they're in hospice, for example, they'll refuse visitors and they'll avoid their family and other people they're close to. You can also find some kids with excess worry and anxiety. They're preoccupied with thoughts and feelings about their illness. So after discussing emotional symptoms, we can look at the physical symptoms. And again, we have to keep in mind that it's difficult to diagnose depression or anxiety in these children because some of these symptoms mimic the symptoms of the illness they're suffering from. So you'll find that the child has fatigue or low energy, even when they've had adequate rest, and they might still keep complaining of exhaustion. And there are changes in sleep patterns. Some children will exhibit insomnia, difficulty falling asleep or waking up a lot during the night or waking up too early. And the child may have trouble relaxing and they feel anxious about sleep. On the other hand, you can have some children with hypersomnia, meaning they now excessively sleep and they find it hard to stay awake during the day. Some of these children will sleep to avoid the emotional distress caused by their illness. Okay, when it comes to appetite changes, some children will have loss of appetite. They lose interest in eating, they lose weight. And again, this might be hard to tell whether it's being caused by depression or as a symptom of their chronic illness. On the other hand, there are some children who exhibit increased appetite and they eat more than usual. I know some of us in this group are stress eaters, so maybe you can relate. So some people, when they're depressed, they tend to eat a lot as a way of comforting themselves. So that can also take place in some children with palliative care needs. Some other symptoms, they may all of a sudden start complaining of headaches or stomach aches or unexplained body pains, even when not related to symptoms of their illness. And some children begin talking slower, they move around slower, they're lethargic. This is known as psychomotor retardation. So the other thing we need to remember is part of the symptoms that are being exhibited, we look at the baseline of this child. For example, was this child previously very active and used to do things with energy? Then all of a sudden they're slowing down, they're talking slowly, they're moving about slowly. So a lot of these symptoms are picked if there's a change from their baseline mannerisms. So then we move on to cognitive symptoms of depression. You'll find that these children have difficulty focusing on tasks and schoolwork. And if you're having a conversation with them, they tend to be easily distracted, forget what you're saying. And when they're playing, maybe they look forlorn and like they're not concentrating on what you're saying. Another cognitive symptom is indecisiveness. You ask them a simple question and the child just becomes overwhelmed because they just can't seem to make that decision. And this could lead to frustration and avoidance of decision making. So another cognitive symptom is negative thought patterns. They have persistent negative thoughts about themselves, their illness, or the future. And these may manifest as helplessness and pessimism. So when it comes to behavioral symptoms, the children have reduced motivation. They are unmotivated to participate in activities, including engaging in their therapeutic interventions. Like a child who previously didn't have a problem, for example, getting blood drawn, all of a sudden they'll be, when they hear blood is being drawn, they'll be unmotivated. So they're also not motivated to do their schoolwork or to play with other children. So this may indicate some underlying depression. Some start self-isolating, avoiding social interactions, and withdrawing from family members and caregivers. Especially we note this, like I said, in kids who were maybe previously sociable and interacting with others, all of a sudden they stop. So another behavioral symptom of depression may be a regression in their behavior, in their milestones. All of a sudden, a child who hasn't bedwetted in years starts bedwetting or thumb sucking. They become really clingy to their caregivers, especially when they're younger or feeling vulnerable. So other symptoms of depression may be suicidal thoughts. If a child all of a sudden starts expressing the desire to die, or they start saying, I wish I could die, or when is death coming? And some of these statements may include, I don't want to be here anymore, or it would be better if I was gone. These are symptoms of some kind of depression. And yes, we understand that these children have chronic illness, but when they start speaking like this, we should always take it seriously. There are others who start talking about hurting themselves. Some children start cutting themselves in a form of self-harm. And this is also an indicator of a depressed mood. So again, if they start mentioning any self-harm, no matter how casual it may seem, that requires immediate attention. So some developmental considerations of depression: younger children who have not developed language yet or don't know how to express sadness will show behavioral changes like tantrums, irritability, clinginess, and regression in their developmental milestones. They may complain about stomach aches, headaches, and this is a sign in younger children that there might be some underlying depression. For school-age children, they're more verbal about their feelings of sadness, hopelessness, or worthlessness, and may act out sort of like with irritability or with anger, or they'll be defiant to what you tell them. School performance may decline and they may withdraw. When it comes to adolescents, they more or less start experiencing depression the way an adult would. They express feelings of profound sadness, feelings of hopelessness and social withdrawal. Although in adolescence, anyone who's dealt with them knows that they can get irritable. And in the case of adolescents with palliative care, increased irritability may be a sign that there's some underlying depression. So these same adolescents may start expressing existential concerns, such as fears about death, fears about the future, how their illness is impacting their loved ones. And for those whose illness has impacted their physical body, they may start struggling with body image and identity issues. So when it comes to adolescents, they also begin to express suicidal ideation and self-harm, especially when they know that their illness is terminal. So we need to look out for that. So there are also instances where we are carrying out a procedure, and the child exhibits some symptoms which could indicate to us that there might be some depression underlying. So I think we mentioned this before, they start avoiding procedures, and especially, again, I'll reiterate that from children who were fine before, but all of a sudden they're overwhelmed with hopelessness and lack of motivation, and they start avoiding medical procedures. In some cases, they're more distressed over physical symptoms like pain and fatigue, and they start saying these symptoms are unbearable, even when you as the clinician can tell that their discomfort is well managed, but somehow all of a sudden they start getting overwhelmed. And let's not say exaggerate, but whatever they're saying is not in line with the management you're giving. So they also have existential and spiritual symptoms, especially the adolescents. They start asking questions like, why is this happening to me? What will happen after I die? And this kind of feelings and thoughts fuel sadness and despair. They may feel disconnected from their faith or beliefs, and they start questioning the purpose of their suffering. And this manifests as frustration, anger, and in some cases, some of them withdraw from their spiritual practices. So maybe as we get into management, we know that palliative care requires a multidisciplinary team to address both the physical and emotional aspects of care for the children. So it's important to keep an eye out for these signs and symptoms of depression, because we want to treat it as early as possible so that the child's quality of life is maintained. Although they may be terminal or end of life or have a long journey with treatment, we want to make sure that their quality of life is at par with their age mates. So the approaches need to be individualized. And in our case, we need to combine psychological, emotional, and in some cases, pharmacological interventions with the aim of improving the comfort, mood, and the overall well-being of the child. So we can begin management with ensuring the lifestyle and environment of the child is friendly. And some of these lifestyle changes or lifestyle enhancements include encouraging regular exercise, because this reduces the symptoms of depression. It boosts your mood and improves self-esteem. For purposes of this session, we won't go deep into how that happens, but we all know there are feel-good hormones like endorphins. So these help. The more you exercise, the more your mood is boosted. So as part of a good environment, we encourage sleep hygiene, which is making sure you don't sleep. You take some time away from screens before you fall asleep. Don't fall asleep with your screen on next to you. Create a nice, cool, quiet environment to sleep in. And this is important because we know poor sleep worsens depressive symptoms. So as part of lifestyle changes, nutrition is important. So we have to make sure the child is getting a balanced diet. For kids, it's important to maintain a routine because this gives them a sense of security and stability. The more they know this is coming next, they're more able to predict and they feel safer, and this will ensure that their moods don't fluctuate, that they're not labile. So if need be, and they're still attending school, they can be given, or there can be a request made for extra time for assignments or provision of counseling services in school. Teachers and school counselors can help in recognizing signs and symptoms and in offering support. So it's important to educate the parents and to have support of the parents or the caregivers. So it's crucial that they understand the signs and symptoms of depression and that they are aware that there are things they can do to support the child. A supportive, nurturing environment at home is important with open communication and patience. This helps reduce stress within the household. So group therapy and peer support groups can help children feel less isolated in their experiences. And we know that the more you don't feel alone, the more you understand that you're not the only one going through something, the more fortitude and strength you have to go through it. So yeah, connecting with others who have similar struggles may provide emotional relief and a sense of community. So when it comes to psychotherapy, we can involve the child in cognitive behavior therapy. And this therapy involves children identifying and getting to know those negative thoughts they have and the negative ruminations they have and recognize that it's a pattern. And through cognitive behavioral therapy, they are taught coping skills and they are taught how to manage their mood. If you start thinking negatively, sometimes a child can start thinking negatively and think everything is negative, whereas it's just specific things that are negative. So they're taught to catch those thoughts and change them in their mind to more positive thoughts. So they can also engage in interpersonal therapy. And this therapy, the basis of this therapy is improving how the child relates to other people. So this will lead to an improvement in their relationships and communication skills. Because sometimes the children are experiencing the depression because they don't know how to move around in social settings. So interpersonal therapy helps teach the people going through it how to relate to people on a one-on-one aspect. So children can also be engaged in play therapy, especially the younger children, because they've not yet learned how to express their feelings and to work through emotional conflict. So those who can't express themselves verbally are encouraged to take part in play therapy. And as we've mentioned, family therapy is important because it improves the family dynamics, communication, and support, and the child feels more supported and less alone. The child can also be involved in legacy building therapy, where they make memory books or videos to live for their families. And this also gives them a sense of purpose and connection. And it probably answers the existential questions they might have, like why am I here? What am I to do here? So we've talked about family therapy and parental support, and the siblings also need to be emotionally and psychologically supported because they're also going through their own grief, anxiety, and depression. So it's important to manage the other symptoms and make sure that the child is as comfortable as possible. So we know that chronic pain, nausea, fatigue can worsen those low mood, that sadness feeling in depressed palliative care children. So it's important to make sure that symptoms arising from the illness itself, such as pain, are under optimum control. So we can do things like taking care of the environment. They can also be engaged in relaxation techniques, such as guided imagery and massage. And this can help with emotional distress. So as we've touched on, there are other integrative and complementary therapies. For example, mindfulness and relaxation techniques, where the children are taught breathing exercises, mindfulness, progressive muscle relaxation, and this helps with anxiety and depressive feelings. So we can include art, music, or pet therapy, which helps to reduce stress, improve mood, and children can express their feelings or just simply enjoy pleasurable activities. So to counteract those sad, low moods that they're having. Okay, it's important to normalize this children's activity, make sure that they are participating in age-appropriate activities, such as playing, engaging with friends, and continuing with their hobbies where possible, as this will give them purpose, and again, those low moods will be counterbalanced. So, like we mentioned, a lot of the children will be like, why is this happening to me? I'm dying anyway. So we can engage in end-of-life counseling. So we counsel them around death and dying, and this helps with the child and the family coming to terms with the difficult realities, and this helps to alleviate fear and provide a sense of peace. When it comes to advanced care planning, the older children can take part in decisions about their care, and this can give them a sense of control and agency, and this will alleviate some of those feelings of helplessness and worthlessness and help alleviate the depression. So as we've mentioned, we can engage them in pre-bereavement support and grief counseling, even for the family. And the goal is to improve emotional well-being while addressing the physical suffering of the child through this challenging journey. So when it comes to medical management, it gets a bit tricky here because as medics, we know antidepressants take 2 to 4 weeks to start working. And you can't, for a child who's suffering with terminal illness, having them wait 2 to 4 weeks is, first of all, you might not have that kind of time. Second of all, they're already suffering and you need to help them. They're already suffering physically. Leaving them suffering emotionally is also not good. So another challenge is that they're taking so many other drugs for their conditions. So drug interactions are more likely and adverse effects are more likely. So in some cases, we use not necessarily antidepressants, but we use stimulants like methylphenidate or low-dose ketamine, which are fast-acting. They're not really for treating depression, but they can improve the mood and just make the child feel better in the short term. While maybe we've started them on the longer-acting antidepressants. So some of these antidepressants include selective serotonin reuptake inhibitors. These are the most commonly used because they've been proven to be safer compared to other antidepressants. I hope most of us clinicians know fluoxetine, and it's the most studied in pediatric population. So it's effective and it's available in a liquid form. If that's not available, or in the case of a child suffering from depression accompanied with anxiety, you can use sertraline. There's a newer antidepressant called escitalopram, but the other two you can use from children who are about 7-8 years. Escitalopram has only been studied from ages 12 and above, but it's more tolerable. It's a newer antidepressant, so let's just say it's more tolerable than the previous two. So it's important to monitor side effects. Again, this is tricky because remember, the patient might still be having nausea and headaches from other medications or from their illness itself. However, it's still important to monitor the side effects, check for sleep disturbances, and we know that antidepressants in the first few weeks of treatment, a side effect that's well known is it might increase suicidal thoughts in some patients. And it's important to weigh the risks of giving these children antidepressants versus the potential benefits. So each patient is treated individually, and we look at, is it better to give these antidepressants given all the side effects and the potential drug interactions versus the risks. So like we've mentioned, they take several weeks to take effect, and we have to be careful when we are stopping the SSRIs so that we make sure there are no withdrawal symptoms. So when we are stopping them, we make sure we taper them slowly. So there are other antidepressants, but not used as commonly. For example, mirtazapine. This can be used in a child with poor appetite because it stimulates appetite, and it also, unlike the other ones, it causes drowsiness. So if a child is having insomnia, mirtazapine is a good one to use, as well as it relieves anxiety. Another one is bupropion. It has stimulating effects, So it can be used in the children who have comorbid ADHD. Yes. So another one is duloxetine. This can be used in children who have accompanying chronic pain because it works on chronic pain as well as an antidepressant. So as we've mentioned, we need to be careful about drug interactions. And we also, and we also need to be aware of any liver and kidney dysfunction in these patients, because this will guide us on the dose of medications we'll give based on the child's metabolic capacity. Because if there's dysfunction, we have to regulate and see how the body is processing the medications. We also have to be aware of oversedation, because remember the child is already on other pain medications or anxiety medications, which may be sedating. And if we give antidepressants that are sedating, we need to be on the lookout for that. So when it comes to end of life, there may be a switch on the long-term goals of treating this depression to just short-term comfort care. So instead of using these long-acting antidepressants, we may choose to use anxiolytics like benzodiazepines, such as lorazepam, in order to just, maybe we've been managing this child and all of a sudden the end of life is getting nearer and they just need relief, emotional relief for those last few days, last few weeks. So in those cases, we just use short-acting anxiolytics like benzodiazepines. Although, like I've mentioned, they don't necessarily treat depression, they just relieve some of that emotional distress. So we've already said this. The decision to use antidepressant is determined by what the goals of care are for this specific child and the family. We have to remember that we are targeting the emotional well-being of this child, and that's our aim as we alleviate depression. And we are ensuring that this child is comfortable, especially as the condition progresses. Yes. We can move on to anxiety. Okay. Just like depression, a diagnosis of anxiety can be challenging in the context of advanced medical illness. Common symptoms like panic attacks, manifesting as tachypnea, tachycardia, and GI symptoms like nausea and sweating may also be coming from the medical condition that this child has, or they could be indicating some form of anxiety. However, just because this is happening, it doesn't mean that we should delay the diagnosis of anxiety. We should aim to pick it up as soon as possible. So anxiety may be because of the emotional, physical, and existential challenges of their illness. So some behavioral and emotional symptoms. The child may be restless or agitated. They may fidget a lot, be unable to stay calm. They may pace up and down, constantly wringing their hands, difficulty sitting still. The child, just like in depression, may be filled with irritability or anger. They are frustrated, agitated. They have mood swings, sudden outbursts of anger, often a response to feelings of helplessness or fear. The child may cry more frequently or seem emotionally labile, emotionally fragile. This may be a response to feeling overwhelmed or scared. You might find the child avoiding things like medical procedures or discussions about the illness, or not engaging in activities they once enjoyed. This may be due to anxiety of their medical condition. So there are also some children are engaged in excessive worry. They are constantly ruminating about their health, pain, death, how their family will survive. And some children's anxiety may manifest as clinginess or separation anxiety. They don't want the caregiver to leave them or their family members. They start fearing being alone or being apart from loved ones. So some of the physical symptoms of anxiety in these children may be increased heart rate or palpitations, shortness of breath or hyperventilation. They may have stomach aches or nausea, and some experience changes in appetite. Some children might get headaches, and just like in depression, there might be fatigue or insomnia. And there'll be muscle tension in some of these children, particularly in the shoulders, the neck, and the jaw. So some cognitive symptoms, just like in depression, they have trouble concentrating on conversations, on schoolwork. They're easily distracted and forgetful. Now, with anxiety comes racing thoughts. They're overwhelmed by thoughts. They're constantly worrying about the illness, about pain, about death. And their thoughts become intrusive. This makes it hard for them to relax or enjoy even a few moments of comfort. Some children become hypervigilant. They're hyper aware of their surroundings and of their symptoms. And they're constantly looking around them, looking for any signs of danger or discomfort. So some social symptoms, some children withdraw from social interaction. They start distancing themselves from friends and family, refusing visitors, and disengaging from social activities. There may be changes in their school performance due to anxiety. This can come from poor concentration, absenteeism, or lack of interest. They have this fear of being a burden to their family or their caregivers. They express guilt or concern about causing stress or sadness to those around them. So some spiritual symptoms, they have a fear of death or dying, wondering what happens after death. They may express worries about pain, the process of dying, and what will happen to their family when they're gone. Just like in depression, they start questioning the meaning of their illness, their life, and they're constantly thinking and constantly worrying and constantly ruminating. Some of them avoid the conversation on death. So there's also procedural anxiety due to the frequent medical procedures they have to go through. And some have anticipatory anxiety. Even before the procedure begins, they start being tense, they start crying, they start expressing fear, distress during the procedure, crying, screaming. And again, like we mentioned in depression, this can happen in children or adolescents who before were calm about all these procedures, but all of a sudden now they're crying, screaming, avoiding, having palpitations, and they may also start fearing the medical staff. When they see them, they just go into a full panic. So when it comes to treatment of anxiety, a lot of it is like the treatment of depression. So we have cognitive behavior therapy. Again, identify negative thought patterns and develop healthy coping strategies. Play therapy for those who can't express themselves, legacy building, as we mentioned, family therapy to have open communication and so that everyone feels supported. Just like in depression, enhanced parental support, and educating the parents and having them involved in giving the child a sense of security. There may be managing their existential anxiety by helping them find meaning of life and faith and peace. So when it comes to pharmacological treatment of anxiety, medication may be used. Again, this is determined by the child's overall medical condition, their prognosis, and their existing treatments. So benzodiazepines are used, such as lorazepam, for that quick relief of anxiety and to maybe provide sedation if the child is too anxious and can't sit still and is pacing and restless. Yes. So long-term management of anxiety is actually using antidepressants. So we talked about the selective serotonin reuptake inhibitors, and they work for both anxiety and depression. So the two common used ones, again, just like in depression, are fluoxetine and sertraline. But like we said, it takes 2 to 4 weeks, in some cases even 6 weeks, for us to start seeing results in managing the anxiety and the panic symptoms. So that's why we use like the benzodiazepines like lorazepam for this acute panic as we wait for the antidepressants to kick in. So just like in depression, duloxetine can be used if there's anxiety together with chronic pain. And we must keep note of any nausea, headaches, or sleep disturbances that may arise. So when it comes to atypical antipsychotics, we can use them if the anxiety is accompanied with agitation or delirium. So we can use antipsychotics such as quetiapine and olanzapine, and these help to stabilize the mood and reduce distress. Remember, this is if there's not only anxiety, but the agitation, and if the child is starting to exhibit bizarre behavior resulting from delirium. But we use this with caution, and only if we really, really have to. We can also use alpha-2 agonists, such as clonidine, especially if they're having difficulty sleeping, because it has a calming effect on the nervous system. So again, trazodone and gabapentin can be used. In some cases, they are beneficial. We've mentioned benzodiazepines, and we've mentioned the antidepressants. So we've talked about this, that the treatment may be complicated by the time needed to achieve therapeutic effects, the drug-to-drug interactions, and we also have to constantly keep in mind the adverse cognitive effects of the medications that may cause delirium in some patients. So we have to remember that a child in pain will be more anxious. So we need to make sure that their pain is managed and that they're physically comfortable. And when it comes to breathlessness and dyspnea, we have to remember that it may be attributed to the underlying condition, and that anxiety often accompanies respiratory distress. In this case, treatment might involve the use of morphine just to ease the breathing, and then this will lead to reduction in anxiety. So we've talked about these techniques, just like in depression: mindfulness and relaxation, music therapy, art therapy, massage, and aromatherapy. So just like with depression, we need to make sure that the child is in a calming environment and that they have school and social support. Make sure there's a peaceful and soothing environment. This includes good lighting, reduced noise, and making sure their surroundings are comfortable. If the child is in hospice or in an unfamiliar place, we can provide them with their favorite toy, maybe a blanket that they're used to, photos, and just provide reassurance. And this will reduce the feelings of fear or loneliness. It's important to maintain social connections with friends, teachers, and family members. If not possible physically, we can work on virtual means to stay connected. This helps the child feel supported and less isolated, and this reduces the anxiety that may be caused from separation. So when it comes to school involvement, they should try as much as possible to continue participating in school activities, even if it's in a limited way. This gives them a sense of normalcy and routine. So anxiety at end of life, they may experience anticipatory anxiety related to the fear of dying, the unknown, or the impact on their family. So discussions about death should be guided by the child's developmental level, their preferences, and comfort. So there should be counseling and end-of-life discussion, which should be open, age-appropriate, led by healthcare professionals, but of course with the input of family members. And this can ease the child's fears and provide reassurance. Spiritual care or counseling that addresses existential questions is also important in managing this type of anxiety. So as we've mentioned, we can use sedative medications such as midazolam, which is a benzodiazepine, and phenobarbital, just to ensure the child remains comfortable and calm. Of course, treatment for anxiety, just like depression, is multidimensional. We focus on the emotional, psychological, and physical aspects. We can use benzodiazepines and other medications as a last resort or in those who really need them. And of course, non-pharmacological therapies such as mindfulness, play therapy, family support are important. And the goal, as always, is to enhance comfort, reduce fear, and provide the child with as much peace and security as possible. That brings me to the end. Those are the references. And I think we can take questions or comments.
Thank you, Dr. for that presentation. So far, does not seem to be any questions in the Q&A segment. Maybe the topic was a bit too tough for them, but
Was it tough? It wasn't clear.
I hope it was none of them, but let's just give them a few minutes. Maybe they will pose questions shortly.
Okay, no problem.
One of the presenters says it's a very interesting topic. Thank you for that comment. Another person says, great presentation, Daktari. Thank you for that. Most of them are thank you messages.
Maybe as we wait for questions, someone can share an experience.
Yes, has anyone had an experience working with children who have depression or anxiety with palliative care needs. Maybe they can share. Purity. Oh, okay. There are some people who have raised their hands. So let me unmute. There is Purity. Purity, I've unmuted you. You can go ahead and share your question. Purity, are you there? Are you
Yes,
ready
I'm
to share your question? Okay, go
yes.
ahead.
I have questions. One is about grieving, bereavement and grieving. If I'm supporting a child who is going through bereavement, maybe, and maybe preparing about death, and maybe talking about grieving and bereavement, maybe is it okay, like to give hope, like maybe our life is in the hands of God? Is it okay to bring that, maybe if you're supporting such a child or maybe the family? The second question is, maybe a child is going through depression or anxiety, and you find that they do not want maybe many people or maybe friends to visit them. As you work on them, you support them through psychotherapy. Is it okay to limit the many people or friends, or it is okay to keep encouraging them for the visitors or the people to be visiting them? Thank you.
Thank you, Purity, for those questions. The first one was about bereavement and grieving and whether it's okay to bring hope. If I think I remember, we had a spirituality in end of life talk, and yes, it's okay to give hope, but you can also it's okay to also let the child know that there's life after death, and to give them hope that everything will be okay. Because remember, some of them are grieving or are in depression because they're worried about what will happen to what will happen to them after death, or what will happen to their family after they are gone. They're feeling guilt about being ill, about being a burden. So yes, it's okay to bring hope, but within realistic boundaries, within realistic parameters. I hope that has answered that.
Yes, yes. Thank
Okay,
you.
and when it comes to a child or an adolescent wanting to be socially withdrawn, it's important, you encourage them to, it's just like adults, you encourage them, but you stay within the boundaries of comfort. I mean, you'll tell them, okay, today at least talk to one person or let one person in another week. Maybe you encourage them, oh, we are doing well, let's now today go and play with these 3 friends, or today have one person visit, in a month have 5 people visit. It's important, you have to strike a balance of what the child wants, where they are, but you also, with your knowledge, you know that social withdrawal is not good. So you reintroduce them to people in a sort of exposure kind of way, slowly. So work within where they are, but also push them kidogo. I hope that answers that.
Sure, sure. Thank you so much.
You're welcome.
I think we can have Rose up next for question. Rose, go ahead.
Hi everyone. My question goes to how do we assess these children, if they have suicidal ideations, especially once they can't express themselves out and they're so quiet, do they experience also suicidal ideations? Thank you.
That's an interesting question. We talked about the adolescents. The adolescents will more or less express, and they'll say it, they might engage in self-harm. For the younger children, this is where we try and engage them in art therapy and play therapy, give them a doll here or there, ask them to express how they're feeling through the doll or express what they're feeling through their art. And you can find that some will draw death scenes or things related to death. And from that, you'll be able to engage and figure out what they're thinking. And from there, you'll be able to guide them and assess them. It's true, it's very difficult. We've said the younger children are not yet conversant with expressing themselves, but we can tease out their thoughts and feelings through engaging them in play therapy, art therapy, acting out scenarios, something like that. I hope that answers that question. And the older children, with the irritability and the anger, you can tease it out of them. You have to sit down and engage them and really talk to them to figure out what they're actually really feeling and thinking. I hope that answers that.
Rose, any response to that? Has your question been answered?
Yes, but I have a scenario whereby we encountered a child of 7 years, and could they tell the parents that I want to die, and at times you could find him alone. He just says, I wish I can get a hole, I go throw myself inside. We were wondering, like, how does this child of 7 years know that there is death? And I think from the presentation, I've come to learn that they also have feelings, and but our worry was, how do you even assess? How do you even support the parents? Because even the parents were not also understanding how this young child of 7 years is able to talk about death. If maybe our presenter can assist us there.
With assessment, unless maybe I go and refer and see if we have any skills to this to find out whether there's a way you can measure. But what I think from my own personal experience, what I've learned is children with palliative care needs are very sort of advanced for their age. They understand things in a way that their age mates don't understand. So yes, even a 5-year-old can understand what death is. So allow me to maybe do some research on if there are other ways of measuring. But yes, some even young ones will express their discontentment with life.
Thank you.
Okay, let's have Triza next. Triza Ireri. Go ahead, please.
Okay, thank you very much. This is quite insightful. I wanted to ask, what is the best way to handle a situation where, let me give an example of a lived experience. A 12-year-old boy, rhabdomyosarcoma of the knee, comes to hospital. The father is not, I don't know what do I say, not a mganga, but believes in cultural causes of that, and the mother is a believer. And so every time the father comes to speak to the child and on the phone with the mother says the baby has been bewitched, and the mother says, no, we are Christians, so now we don't believe in this. And the boy hears everything. So the point at which the boy comes to the hospital depressed with all the signs and symptoms like has been shared here, and he is struggling between wanting to get better and also the fear of an amputation. So, but every time the father comes and fuels this thing that you're going to die when you get amputated or if you continue staying in hospital. So how do you handle this scenario where you're having a lot of negative energy coming one way and then on the other side? So the boy is confused because he's in between there, and you realize that he really values the father and what the father stands for in his life. So what is the best way, how is the best way to handle that? Over.
Thank you for that question. I think in this case, it's more of dealing with the caregivers, with the parents. Just confirm, does the father come to hospital ever?
Occasionally.
Because maybe it's like what we do for adults. You sort of try and respect where the father is coming from, but at the same time, you try to give the medical interventions. You can, like we usually get a lot of patients who come and they believe that their mental illness is caused by witchcraft. So what we do is we try to engage them from a medical point of view and just calmly mental health is very challenging, and calmly try to educate them. And you can bring in scientific, but not in a jargon kind of way, but in a way to just try and explain to them, try to educate them as far as you can, as much as you can medically, and just explain that it might not be witchcraft, it might be just an illness that has been caused by genetic condition, blah, blah, blah. Then you get to the root of it, and then hopefully by the end of the conversation, the parent has understood that yes, this may actually really be a medical condition, and you might have changed their mind and convinced them to seek the medical treatment. So in that case, does the father have the final word?
Absolutely. So we are here. It's the father has to give the final word, and because he knows that, so he came to hospital, saying that the mother, not the wife, is his sister, so that he's not consent. Yeah. So it really went on for a long time, and then he disappeared. So one day the mother just consented in his absence. Then he refused hospital. After that, after the amputation, he refused to come to hospital completely, and that drove the boy down completely, where he became very angry. He was throwing tantrums, and it was all connected to the phone, because the mother used to say every time he gets the phone, he looks at the phone, he wants to see whether try to reach the father. Then when he couldn't get him, he used to throw away the phone, and he refused to eat. So he was still craving for the father to come along, because he knew that the father had not consented. The father was not, but together with his mother, he was okay when the mother consented to go. But still he got lost in between there, like what will the father say when he comes, and the father is not coming. Yeah. So it really took a while before he could calm him down. But then a lot of psychological support for him happened, and until he came up. So at some point, the father came also, but later
Yeah.
on,
Mhm.
yeah.
Yeah, and that's where the psychosocial support comes in, because that boy really needed to be supported and to understand that it's not, yes, it was important for him to have his father by his side, but to understand that there's also other social support available. Thank you for that interesting scenario.
Thank you.
Yes, Teresa, thank you for that interesting scenario. I also have to acknowledge that that is a difficult situation to maneuver. So yeah. We have, I believe we have David up next. David, go ahead.
Hi, a good session. We truly appreciate what we hear. My hand was up just to make a comment based on the question around spirituality for children. And remember, we insist as we engage and as you guide, responding to purity, that it is important to be keen on the child's spiritual perspective and not our own perspective. So trying to listen more and want to understand what is the child's interpretation of the supreme being, what are their thoughts around end of life and death, other than just blanketly saying God is in control, but wanting to understand what does that really mean to the child based on their upbringing, based on their, teachings. Is it from madrasa? Is it from Sunday school? Is it from whichever kind of spiritual perspective? So that is what I wanted to point out, and also to answer Rose's question around assessment. I've shared a link of some tool called Magnify Tool, which was recently launched through initiatives by Global Tree Foundation and led by Erin with other team members. And also the APCA post could be a good reference point, and we could share more even as we engage. But I like that discussion. Thank you.
Thank you, David, for that. And thank you for sharing that information.
Yeah, thank you for those points and for sharing the tool. Thank you so much.
Let me see if we have any more questions. There doesn't seem to be any more raised hands. Maybe we can give people a minute to see if they can come up with any questions. Okay, I don't think there are any more questions. Thank you, Dr. Weremba. This was such an informative topic, and I'm sure so many people have learned a lot. I think if there are no more questions, we can end here, if everybody is comfortable. Dr. Weremba, is that okay with you?
Yes, that's okay with me. And if anyone has any questions at any point, even about dosages or any more information from the psychiatric aspect, feel free to ask in the group.
Oh, somebody is asking about slides. Emily, I don't know how we can organize that.
Thank you, Dr. Valerie. We'll talk with Dr. Weremba, but also this will be put up on our YouTube, so people can always listen in. But in
Okay.
terms of the notes, I will discuss with Dr. Remember.
Okay. Okay, everyone. Thank you for your participation in this session. I hope you have a lovely rest of your evening. Thank you so much for your participation.
Thank you, Dr. Valerie. Thank you, everyone.